So, good afternoon, everybody, and welcome to the MedEClasses postgraduate lecture series on acquired hypothyroidism. Over the last 2.5 years, we have been working on different modules related to pediatric endocrinology, and the PG lecture series has covered many like growth, calcium, electrolyte, along with thyroid and pubertal disorders. So, we are going now towards acquired hypothyroidism. And acquired hypothyroidism is one condition which is quite common from a pediatric perspective and something which has implications in terms of short and long terms from different aspects, not just growth, but puberty, but many other issues. It can also be a cause of emergency, as was seen in this case. This was a 12-year-old boy who had presented to us with poor school performance. And at that point of time, he was found to have a low FT4 and a TSH of 9. At that point of time, the treating physician considered that this is a hypothyroidism. It's more likely to be a primary hypothyroidism because TSH is slightly high, and started on thyroxine. But within a couple of weeks, the child developed hemodynamic instability and shock. And what really went wrong here was that there was an erroneous assessment in terms of thyroid function. In that, when we remember that whenever the FT4 levels are low, we expect the TSH levels to be very high. If they are not high, this suggests a central hypothyroidism. So this was a central hypothyroidism with associated multiple pituitary hormone deficiency, which was missed and resulted in this abnormalities in terms of treatment. So clearly, this is one condition which is quite common, but often can cause a lot of confusion in that perspective. So this is a rare form of acquired hypothyroidism. We'll be discussing a lot about this in that regards. All of you can go and have a look at our website, learning.growsociety.in, which has got multiple sources and resources regarding pediatric endocrinology, our e-learning platform, our courses which are there, along with our fellowship and pediatric endocrinology for postgraduate courses. We run a number of activities every month, including this PG lecture series, grand rounds, and journal clubs. And we have multiple publications ranging from pediatric endocrinology protocol to basic and advanced pediatric endocrinology. And our app provides comprehensive assessment of pediatric endocrine disorders, including thyroid interpreter, which is also available. So today we're going to focus about acquired hypothyroidism. And before that, we need to understand a basic physiology. So we all know that the hypothalamic thyrotropin releasing hormone, which is one of the smallest hormones, it has got only 3 amino acids, goes and acts on its receptor in the thyroid, in the pituitary to produce TSH, which acts on its own receptor, TSH receptor, which is basically a GNAS mediated pathway, resulting in production of T4, which essentially is a prohormone. This T4 has to be activated in the target tissue via monodeiodinase 1 into T3. There is also a certain amount of T3 which is also produced by the thyroid gland directly. So what we need to remember is that while most T3 peripherally is coming from the conversion of T4 to T3, around 20% may be coming from the thyroid itself. So if you have somebody who has athyrosis, if you keep your thyroid levels, T4 levels in the normal range, your T3 may not be high enough. So that's why you want to keep your T4 in the high normal range in the treatment of somebody who has got no thyroid gland at all. Now, this T4 is bound to TBG to a greater extent, and T3 is also bound to TBG. So the free form is only 0.3 to 0.03%. So vast majority of the thyroid hormone which we are measuring are actually the total hormone, and they are not good reflectors in terms of the actual thyroid status. And in conditions where thyroxine binding globulin may be affected, like pregnancy, like estrogen exposure, like liver disease or nephrotic syndrome, we should actually go ahead and do a free thyroid hormone assessment from that perspective. Now, thyroxine, which I'll talk a bit later about how it works, goes into the cells using a MCT8 pathway, acts on the thyroid receptor to cause its function, and this is going to suppress the TSH receptor levels. So the first thing to happen in somebody who has a problem in the thyroid or primary hypothyroidism is the elevation of TSH level. This will be followed by decrease in T4. The body will try to keep the T3 levels normal by increasing the monodeiodinase activity. So the T3 fall will be the last one. So T3 is the least important or most useless test in the assessment of primary hypothyroidism. In somebody, on the other hand, if there is a central hypothyroidism, like the first case which I discussed about, therein your FT4 levels will be low, but the TSH levels will not be that much high. And this is, although they should be actually zero if we talk about central hypothyroidism, but we do see that the TSH may be marginally elevated. But that TSH will be inappropriately normal for somebody who has a hypothyroidism. So anybody whose T4 is low, TSH should be very high. So even if you have a detectable TSH or TSH is going above 10 or something, you start thinking that this could be something else in that perspective, and central hypothyroidism should be suspected in that regards. Now, we know that thyroid is a group of glycoprotein hormones. So there is a post translational glycosylation which happens, and structurally it has got two basic polypeptide chain, the alpha chain and the beta chain. The alpha chain is structurally similar to other hormones like LH, FSH, and HCG, causing an overlap, while the beta chain provides them specificity. So what you can see is that the TSH can act on the LH receptor, it can act on the FSH receptor and on the HCG receptor. The predominant effect of TSH is on the FSH receptor. And similarly, HCG, if the levels are very high, they may act on the TSH receptor to cause thyrotoxicosis from that regards. So if your TSH levels are very, very high, it may act on the FSH receptor, resulting in development of large ovarian cyst with peripheral precocious puberty, which is known as von Wieck-Grumbach syndrome in that regards. In the testis, this TSH will also going to work predominantly on the Sertoli cells, not much in the Leydig cell, causing macroorchidism without pubic hair. So somebody who comes to you, a boy who comes to you with large testis, but is prepubertal, think hypothyroidism. A girl who comes to you with precocious puberty and short, think hypothyroidism in that perspective. Now, placenta produces a lot of HCG, and during pregnancy in the mothers, this will act on the TSH receptor to stimulate the thyroid, producing a thyrotoxicosis-like state. And this clearly can also have an effect from that perspective. So this overlap is there from that regards. I've already mentioned that only 0.003% of T4 and 0.3% of T3 is roaming around freely. Most of it is bound to binding globulin, and the most important of them is the thyroxine binding globulin TBG, which is produced by the liver, accounting for 75% of transport of thyroid hormone. Albumin also plays a role, again around 15%, ensuring a faster delivery, and transthyretin TTR is also responsible mainly for the T4 binding produced by the liver and choroid plexus. So in conditions where we have excess or deficiency of these binding globulins, there may be confusion in terms of assessment if you look at the total hormone levels in that perspective. So estrogen is going to increase the thyroxine binding globulin. So in girls who are on estrogen progesterone and somebody who is pregnant, you expect the T4 levels to be high in that perspective. So these conditions will have a high total T4, normal FT4, and a normal TSH do not need treatment. But this would have implications in terms of requirement. So do you think this is going to increase or decrease the dose requirement, Dr. Alapan?
It will increase the dose.
Why?
Key portion of the thyroid is decreased amount because of the binding globulins is high.
Okay, so you need to increase the dose. Definitely, pregnancy, the requirements will go up. Now, testosterone and glucocorticoid work the other way around. They will suppress the TBG production, and therefore they will result in a situation where your total T4 will be low, FT4 is normal, and TSH is normal. Again, no need of treatment. Very important agent, particularly heparin. Whether you're using it in vivo, like you're given heparin to somebody, or in vitro, in the capillary wherein heparin was given, that may displace the thyroid from the binding globulin and may result in a very confusing picture of high FT4, and TSH will be normal in that perspective. So, because the T4 has been displaced from the binding globulin, that's why this picture may come up. Nephrotic syndrome and chronic liver disease will also influence the albumin level and therefore result in a low level of T4 from that perspective. Now, thyroxine is a very unique group of hormones. We talk about there are protein hormones which cannot cross the cell membrane, and therefore we have got the extracellular receptor. We've got the steroid hormone which can readily cross through. But thyroxine is a unique hormone. Thyroxine is chemically what structure, Dr. Nimisha? So it's a amino acid derivative. So it is basically not a lipophilic hormone. So it cannot come into the cell. So how does it enter the cell? So not really messenger, there is a sort of a chaperone. You can say a transport protein. So MCT8, which is there, which takes the thyroxine in. So there is a specific delegation which is sent to bring, receive. So it's so important for the cell. In a very, very crude way, I can say that they're so important that they're sending somebody to receive it and bring it inside. Once in the cell, it binds to the nuclear receptor. Now remember, the steroid receptor is intracytoplasmic. It is not nuclear. Here it is nuclear, and there the receptor is usually dimerized via the retinoic acid receptor RXR. And once it binds, it will have the production of various mRNAs producing protein and the effect of that. There are multiple isoforms of thyroid receptor. So we have got the TSH, the thyroid receptor A, which is in chromosome 17, and thyroid receptor B, which is in chromosome 3, resulting in different effects of resistance to thyroid hormone. Whether A is affected or B is affected, the clinical manifestations will be different. So therefore, you have got the various units which allows a site-specific action from that regards. Now, thyroid, we all talk about head to toe, every part of the body is affected. So it affects the bone strength, and there is a specificity as to which receptor works. So alpha 1 works on the bone, increasing the strength and growth. The brain development again is alpha 1 and partly beta 1, and this is involved in every process. So neurogenesis, synaptogenesis, myelination. So right from the initial to the final stages, thyroid hormone is essential for brain function. It of course is sort of a thing which will increase the heart tone. It will cause contraction of the heart. It also has an effect on the sodium potassium ATPase and sodium calcium exchanger. So we are not talking about thyrotoxicosis here, but if you have thyrotoxicosis, you may have rhythm abnormalities, particularly atrial fibrillation, because of these conduction issues which thyroid does in that regard. It will increase the non-shivering thermogenesis. So somebody who has hypothyroidism will have more body fat from that perspective. Very important role is in the liver, where it is involved in SHBG production and lipolysis and lipogenesis as well. So even subclinical hypothyroidism may be associated with fatty liver disease because of this process. And intestine motility again becomes important. So every part of the body, this may be affected. It is expressed in the muscles, especially TR alpha, causing contractility and inhibiting CPK. We know that patients who have uncontrolled acquired hypothyroidism may mimic Duchenne's muscular dystrophy, in the sense that they will have large muscles. They will have a very high levels of CPK, which may be seen in that regards. There's also a very important crosstalk, as we already discussed. So TSH acts on the FSH receptor to cause ovarian cyst and peripheral and a sort of a macroorchidism in boys. That will be the more common scenario in that regards. Very importantly, the regulation of prolactin and TSH are very, very similar. So the same hormone dopamine or same neurotransmitter dopamine inhibits both prolactin as well as TSH. The same hormone, thyrotropin releasing hormone, stimulates dopamine as well as TSH. So somebody who has hypothyroidism will have a highly elevated level of prolactin. Anybody with hyperprolactinemia, first thing is to look at is the thyroid level. Dopamine and glucocorticoid are going to inhibit the TSH, therefore causing a low level. That's why children, newborns who are in the ICU may have a falsely negative screen once you do that. Individuals who are in the ICU, they will have a low TSH causing what looks like central hypothyroidism, but it's actually a non-thyroidal illness. We'll talk about that in detail. HCG, we already discussed, starts acting on the TSH receptor, inducing a thyrotoxicosis-like state in that perspective. Very importantly, the adipocyte leptin product from there stimulates the TRH to increase the TSH. So in children with obesity, you may have mildly elevated level of TSH, which is the effect of obesity, not the cause of obesity. And we'll talk about all that. So acquired hypothyroidism could be primary. The most common cause is primary, where your TSH is high. Most common is autoimmune. Others could be rarely infiltration, iodine abnormalities, or radiation damage. It could be secondary or central because of the problem in the TSH receptor. multiple hormone or TSH beta. And finally, you can have a thyroid hormone resistance because of either the MCT8 problem, the monodiiodinase problem, and here again, you will have high TSH and T4 with low T3. So I'll now invite Dr. Nimisha to talk about further in terms of etiology of acquired hypothyroidism.
Thank you, sir. Acquired hypothyroidism causes can be transient, which include non-thyroidal illness, obesity, iodine deficiency or excess, which is can be due to amiodarone, drugs like anti-thyroidal drugs, lithium, anti-epileptic drugs, tyrosine kinase inhibitors, or interferon alpha. There is a permanent cause, of which the most common is the primary hypothyroidism, among which the most common cause of primary hypothyroidism being autoimmune causes, which include APS1, APS2, isolated causes, or IPEX, associated with IPEX syndrome. It can be a missed congenital hypothyroidism, either dysharmonogenesis, hemiagenesis, or pseudohypoparathyroidism, or insult due to radiation or a surgery, or associated with any syndrome like DiGeorge syndrome or Prader-Willi syndrome. It can be a central cause, which includes MPHT, thyroid receptor hormone defect, or TSH beta defect, or impaired action of thyroid due to resistance to thyroid hormone action, MCT8 defect, or increased consumption as seen in hemangioma. The primary hypothyroidism, there is a decrease in T4, resulting in increase in TSH and further increase in TRH. The increased TSH will act on FSH receptors, resulting in development of ovarian follicles, which can present in girls with precocious puberty and in boys with macroorchidism. The TRH, which is increased, will cross-react with prolactin, and there will be increase in prolactin levels as seen. Therefore, the effect in primary hypothyroidism is increased TSH, low T4, low T3, and low free T3 levels. The 95% of the cases we see are primary hypothyroidism, in which there is the first rise in TSH is seen, then T4, and the role of T3 is very limited in diagnosis of primary hypothyroidism. The most common causes being autoimmune, iodine deficiency and excess is seen, and insult with radiation or surgery or is the common causes of primary hypothyroidism. Autoimmune thyroiditis can be two types: atrophic thyroiditis or a goitrous autoimmune thyroiditis. Atrophic thyroiditis is a uh, cell-mediated immunity due to thyroid receptor blocking antibodies, which results in shrinking of the size of the thyroid gland, resulting in atrophy. And could be a goitrous autoimmune thyroiditis, which is also T cell mediated due to thyroid stimulating antibody or thyroid inhibitory antibody. It can be both, or TSH antibody associated. The 50% of the cases have goitrous, rest are atrophic variant. The TPO positivity seen in children with normal thyroid function, there is 10% chances that they will progress over 5 years duration. Therefore, only TPO positivity is not treated.
So this is an important because a lot of patients are referred to us with TPO positivity. So the chances you do annual TSH will be recommended in that regard.
Thyroiditis in general is association with, in general population, 6% are TPO positive and 10% are thyroglobulin positive. 3% of thyroiditis is associated with beta cell immunity, and less than 1% is associated with adrenal immunity. And there's also association seen with celiac and pernicious anemia. Therefore, there's no routine screening is required, as the association is less than 1%. Only screening for type 1 diabetes or adrenals is done if there are symptoms like vitiligo, pigmentation, polyuria, or GI symptoms. And if there is increased requirement of thyroid hormone, the child should be screened for celiac disease. Thyroid autoimmunity. Celiac disease have 10 to 20% of autoimmunity, and we should follow up annually for thyroid disease in celiac. Type 1 diabetes have 20% TPO positive and 5% are hypothyroidism. Should screen at diagnosis and then followed up at 1 to 2 years. Down syndrome at 28% antibody and 20% are hypothyroidism. Should be screened at 0 months, 6 months, and 12 months, and then annually. Turner syndrome, 15% of them have a thyroid autoimmunity, and more is seen with iso-XQ chromosome, and they should be followed up annually. Klinefelter syndrome, 10 to 12% should be followed up annually, and APS1, 10%. Annual screening should be done, and APS2, 70% of them have chances of thyroid autoimmunity and should be followed annually.
So while you don't need to do other screening in somebody with hypothyroidism, if somebody has other autoimmune, thyroid is done in everybody. So this is a general principle that if your disease is very common, you don't screen. So you screen only for disease which is rarer than it. Then you will do it for everybody.
IPIX, 50% and should be screened at diagnosis and annually. Thyroid hormones are damaged due to a radiation effect, which can be a scatter radiation given or a cervical radiation given, or it can be affected by tyrosine kinase inhibitors or chemotherapy like busulfan if given. Uh, it can lead to hypothyroidism, most commonly in 60 to 70% after radiation effect, which is progressive and can be detected early. Can present as thyrotoxicosis if the radiation dose is very high, more than 35 gyri, which is transient and it is due to cell-mediated immunity. Can present as thyroid nodule, which also occurs with 20 to 30 gyri of radiation when given. Can be monitored with neck palpation on anybody with on radiation. Ultrasound can also be done. Management should be done as per the guideline of thyroid nodule. Treatment of subclinical hypothyroidism should be done in a child receiving radiation to avoid tumorigenesis in them.
I think that's a very important point. Anybody who has had radiation or is predisposed to a thyroid cancer, you need to keep TSH as absolutely normal or a low level. So hypothyroidism should definitely be avoided. So this is one subclinical which is absolute indication to start thyroid.
Yes, sir. Syndromes associated with hypothyroidism, DGeorge, there is 25% prevalence of having hypothyroidism. It presents with hemiagenesis. There are other features which help in more diagnosis of DGeorge like hypoparathyroidism and cardiac defects. Williams, 32%, which is reversible. Prader-Willi, 4% of them are primary hypothyroidism, 7% of central hypothyroidism is seen. Central hypothyroidism occurs when there is decrease in T4 and T3 levels, but not substantial increase in TSH as compared to the decrease in levels. There is low TSH, TSH, low T4 and low T3 levels. It can be isolated or associated with MPHD. The diagnosis is made on low T4 or normal or low TSH, which is the bioinactive form of TSH which is present. It could be due to TRH receptor defect, TSH gene defect, or MPHD, or malformations which is associated with HESX1, PIT1, PROP1 gene. Tumor, trauma, or infection can lead to central hypothyroidism. Consumptive hypothyroidism, there is more activity of DIO3, which results in more conversion of T4 to reverse T3, seen in case of hemangioma. It is associated with more increased requirement of thyroid hormone and high reverse T3 levels, and high treatment is with high dose of thyroxine, or we can give high dose of thyroxine, or we can give some.
You can use either high dose of thyroxine or you can go ahead and use T3 also, which is now available.
TRH receptor defect. There are two types of TRH receptors as told by sir, TRH alpha 1 and TRH beta 1. The most common being TRH beta 1 defect, which presents with irritability or hyperthermia. On lab parameters, there is high FT4 and high FT3 with normal TSH. treatment is by beta blockers or thyromimetic can be tried.
I think this is very important to remember that there are two different receptors. So if one is not acting, your entire function will shift to the other side. So you will have features of both hypo and
And
hyperthyroidism. So people used to call it earlier pituitary resistance to thyroid hormone or peripheral resistance. Now we know it is because of the subtype of the TSH receptor which is there. So again, very important. So what you can do is that you can use the agent which is going to bypass this process. So triac, which is used in that regards. Okay.
MCT8 receptor defect. It is an X-linked defect. It is result in impaired thyroid transport. It presents with hypotonia, spastic paraplegia, dysmyelination. And on lab investigation, there is high T3, low T4, and mildly high TSH. Can be treated with triac and fetal treatment is
So
required.
this is a very, very important condition. And this is one condition. So I had told you that T3 has got a limited role or it is useless in the evaluation of primary hypothyroidism. But this is one condition where T3 will be very helpful. Now remember, these cases will not look like hypothyroidism. They will look like more like a neurological involvement. So if you think of somebody who is severely neurologically deranged, in that setting, T3 also should be done because otherwise you may not pick it up much.
Non-thyroidal illness. During illness, the levels of MDI3 increases and there is decrease in MDI1 activity, resulting in more levels of reverse thyroid hormone and decreased level of T3. In brain, there is increase in MDI2 activity, resulting in more levels of T3 and then suppression of TSH. This is basically a protective mechanism during illness, which is supported by high levels of cortisol and cytokine levels during illness. The raised T3 in the brain will suppress the TSH levels. The dopamine also inhibits the TSH, and the cortisol also have a direct inhibition to TSH levels, resulting in reduced TSH, and the cytokine produced during illness will inhibit TRH, so resulting in reduced TRH levels. Therefore, during illness, we find low TSH, low T3, and a low T4 levels. During recovery, the activity of MDI1 increases and MDI3 activity decreases, resulting in increase in T3 levels and decrease in reverse T3 levels. In brain also, there is increase in T3 levels and hence there is seen of high TSH levels seen during recovery. However, the level of rise of TSH is more compared to the rise of T4 and T3. Therefore, during recovery, we see high TSH, low T4 and normal T3 levels. So we should not, we should avoid screening for thyroid during illness, and if any abnormality found, it should be followed up after 3 weeks. And treatment should be done only if TSH is more than 10. A non-thyroidal illness, the assessment should be only be done if it is essential with free T4 and TSH levels. T3 and T4 are optional. TSH levels are low during illness. Assessment is same as low. Significant when TSH is very low, less than 0.01, or TSH is more than 10. Then it should be treated. It is highly sensitive marker. T4 levels are low. Assessment is lower. Significance if the T4 levels are high, and we should track and follow. FT4 levels are low during illness and assessment is variable, and there's an unclear significance of free T4 levels, and we should avoid doing them. And T3,
either if you're doing it, then you should do it using equilibrium dialysis, which is not available in most centers.
T3 levels are also low and assessment is variable and unclear significance of T3 levels, and we should track them if found low. Obesity, there is a lot of adipocytes present in obesity, which result in increased levels of leptin, which causes increased expenditure of body metabolism, resulting in increased TRH and increased TSH. And but there is normal T4 levels. So obesity, we found high TSH, normal T4, and a normal T3 levels. It is a compensatory mechanism of a body to increase resting energy. It is reversible and no treatment is required. Drugs which causes hypothyroidism are phenytoin and phenobarbital, which inactivates thyroid hormone. Lithium causes impaired release of thyroid hormone. Dopamine and steroid causes TSH inhibition. Tyrosine kinase inhibitor and interleukin 2 affects the thyroid production. Amiodarone affects the thyroid hormone by iodine excess. Valproate causes central hypothyroidism like picture. Subclinical hypothyroidism, when there is judge when there is FT4 levels are normal and TSH is between 6 to 10. The causes can be autoimmune or TSH receptor antibody. It has high chance of remission, and treatment is only done if TSH is more than 10 or TPO positivity in 6 to 10. Trisomy 21 abnormality can be dysgenesis or autoimmunity. There is a low normal FT4 and a high normal TSH is seen. Plan is to treat only if TSH is more than 10. And screening should be done at birth, 6 and 12 months, and then annually.
And the problem in trisomy 21 often is that you will have fluctuating course. Sometimes they have hypothyroidism and thyrotoxicosis because they have got dysgenesis, autoimmunity, everything going on. So thanks a lot, Nimisha, for focusing on this aspect of thyroid disorders, particularly the etiology. And we'll now focus about assessment of thyroid disorders. The key questions are, is it really hypothyroidism? Is it transient or permanent? What is the site, central versus peripheral? And what's the cause in that regards? So thyroid disorders, pretty much everybody who comes to us with pediatric endocrine practice requires the thyroid assessment. So anybody whom you're thinking of endocrine, think thyroid. It can cause short stature, early puberty, late puberty, cardiomyopathy. We have seen patients who presented to us with large heart because of pericardial effusion, hyponatremia, developmental delay, hyperandrogenism, fatigability. So in just the classical manifestations are there, but other manifestations can also be there, which we need to be cautious about, including emotional lability and other parameters which are there, which we can identify. Very importantly, if there is problems in the lipid profile, CPK is high, prolactin is high, there is anemia or hyponatremia also, we should always do a thyroid profile from that perspective. One condition, of course, which we have seen is the cellular mass. They present to the neurologist with headache and they found there is a large pituitary and they refer as cellular mass, but which is because of hypothyroidism. So thyroid function assessment we already discussed that we expect that for anybody who has low thyroid, TSH should go up, T4 will go down and T3 will be the last to go down. So in hypothyroidism, we should do both FT4 and TSH. First investigation, everybody should be FT4 and TSH. With an exception, somebody who has neurological findings, there you do T3 also to identify the MCT8 defect. So 6-year-old boy with short stature, height is 92 centimeters, weight is 16, coarse skin, TSH is normal on 3 occasions. So do you think this could still be hypothyroidism, Dr. Alapan?
Test probabilities are high in this case because the height is short.
Yeah, so TSH is normal. What was being wrong in this case?
I would like to see the T4 level. T4 level.
So here the FT4 was not done. So this is a common error. People just do TSH and then they don't identify the scenario from that regards. Remember that TSH levels does show a variation, a diurnal variation with the highest level in the morning. But this variation is not enough to allow only timely assessment. So when you say cortisol, you say 7 to 9. When you say cortisol excess, you say midnight. But in TSH, this variation is not that much. So you can do it at any point of the day. So there is 40 to 50% diurnal variation. Within an individual, it's also around 0.5. And within two different individuals, it will be 2.5. So what does it mean? It means that if my TSH was 2 consecutively and it becomes 4.5, this means that this is going up. While if another individual, the TSH was 4, it becomes 4.5, the implications are not the same. So for the same individual, you expect TSH to be within 0.5. But within other groups, you can have variation which can happen. You already discussed that TSH varies with age. So we are not talking about neonatal period. Generally, we don't treat below 10 and below 6 only. After 6 only, we start getting worried in children. The chances of reversibility of subclinical hypothyroidism in children is more as compared to adults, which has been shown, particularly if they are obese. Thyroid hormone levels, there are receptor. We need to remember that we have options of total and free hormones. Total hormones are affected by TBG, but there are robust assays. Free T4 is not affected by TBG, but there could be variability. And if you want to get really sure, you need to do an equilibrium dialysis, which is very expensive, not easily available. The heparin effect will not be there in total hormone because heparin releases free T4 from the binding site, and non-thyroid illness free T4 is not very good. So while generally FT4 is a good test in the preterm child, during pregnancy, and during the non-thyroid illness, it may not be a very reliable test in that regards. We've discussed about binding globulin already, that you can have estrogen, which is going to cause increase in TBG, testosterone glucocorticoid, which will cause decrease in TBG. You can have a problem in terms of nephrotic syndrome, CLD, where the levels will be low, and these can have a significant impact. So Dr. Nimisha, a 10-year-old girl with poor concentration, she is having some short stature, but not that much. Clinically looks euthyroid. TSH is normal and T4 is low. So do you think this is central hypothyroidism?
No, sir, I would like to see pre-T4.
Because central is a quite uncommon scenario. So FT4 should be done. And in this case, FT4 was found to be normal. So this could be a TBG defect in that perspective. 17-year-old girl, Dr. Vibha, with hyperandrogenism. BMI is 28. So she is obese. And you find very bizarre report. The gynecologist has referred as thyroid hormone resistance. High T3, high T4, and TSH is normal.
So both the T3 and T4 would be high in this case because of the use of OCP pills for
Yes.
hyperandrogenism.
So we should definitely ask for the estrogen exposure in this case, and FT4 is normal. So that gave us a clue. So we always vary about whenever you're using total hormones, whether there is any confounding state or not. So estrogen progesterone gave a picture. 11-year-old boy with liver disease, sodium is 120. So there is hyponatremia. At that point, urinary sodium was also on the lower side, and thyroid profile showed very low T3, T4 and a TSH which is normal. So again, do you think this is central?
Probably at the setting of the liver disease, I think the albumin levels and other binding globulin should be low, causing this low T4 and T3 levels.
So cortisol in this case was found to be also low.
So,
So this is MPHD.
slide down because
So again, this could, the CBG levels will also be low. So clearly in this case, this is because of the liver disease rather than other scenarios. So now once we know this is hypothyroidism, next question is transient. So look for obesity, drugs, which Dr. Nimisha talked about, illness becomes important from that perspective. Then how do we interpret the site of thyroid defects? So we know that if FT4 is low, TSH should be extremely high, above 20. If the FT4 is low and TSH is below 20, this is most likely to be a central one. You need to do further evaluation in that regards to rule out the cause as we discussed. So workup will depend upon the clinical scenario. So look for goiter. If the goiter is there and the goiter is hard and bossulated, that is more likely to be autoimmune thyroid disorder. Absolutely soft like a rubber ball, this will be dysharmonogenesis. Antibody status is good, but you don't need to do it in everybody. If somebody can't afford, do it only if there is subclinical, where you have a doubt of treatment. Here, TPO and TG both are recommended, but you can do TPO alone because it has got higher sensitivity and specificity. TRAM antibody should not be done. It is no role in that perspective. So as discussed, around 90 to 100% cases will be positive for TPO, 80 to 90% for thyroglobulin. Also remember that 10 to 20% normal children will also be TPO positive. And Nimisha said that if you follow them up for 5 years, only 10% will develop hypothyroidism. So many patients come to us with TPO levels. We are not very that much worried. Ultrasound is not indicated in everybody unless we are suspecting nodularity. So if you have TPO positive with asymmetrical goiter, then you can start thinking of nodularity, get an ultrasound done from that regards. Nuclear scan, again, only if you're suspecting a rare possibility of missed congenital hypothyroidism. Somebody with an absolutely soft goiter also has severe growth failure, has some mental subnormality. You should start thinking of a possibility in that regards. Anybody who has central hypothyroidism, FT4 which is low, and TSH which is not high, get a MRI done and anterior pituitary functions in that perspective. So how do you approach hypothyroidism? Look at FT4 levels. If the FT4 is low, look at the TSH levels. If the TSH levels are above 20, you are sure this is primary. Below 20, and some guidelines talk about 10, but I would be more cautious. I've seen patients between 10 to 20. You should look at MRI and cortisol. It may still be both central and peripheral. If the FT4 is normal and TSH is below 6, don't worry. If TSH is more than 10, most likely treatment is required. Between 6 to 10, assess risk factors like TPO positivity, goiter, family history, or a girl child. There the chances are more. There is controversy about which girls, children require treatment, but generally if they are above 6 and TPO positive, we start treatment from that regards. Otherwise, better to follow them up over 2 to 3 months, where we'll get the idea about that. Very importantly, and this was raised by Nimisha about non-thyroidal illness, do not do a testing unless it's absolutely essential. Do FT4 and TSH. If your TSH is very, very low and FT4 is high, then it is thyrotoxicosis, very rare scenario. If your FT4 is normal, then nothing to worry, you wait and watch. If your TSH is low, but not that low, so it is in the slightly detectable range, then you do a cortisol level. If cortisol is low, that could be a multiple pituitary hormone deficiency, or if the cortisol is very, very high, this will be a non-thyroidal illness. So whenever you are interpreting reports, cortisol gives you a clue. If the cortisol is above 550, this means it's a stressed patient. That's why you have got the non-thyroidal illness. If the TSH is normal, you don't need to do anything, follow up. If it's 4.5 to 10, now this is important. You expect that with illness, TSH should be low. If TSH is high, that is very, very significant. So if your TSH is 4.5 to 10, repeat after 1 week. If it's more than 10, look at FT4. If FT4 is low, you treat. If it's normal, you can repeat from that perspective. So 12-year-old girl with obesity, Dr. Alapan, TSH is 6.2, advised treatment. Do you agree?
Sir, this is widely elevated TSH. Girl is already obese. So probably this is the effect.
So this is the effect and not the cause. There is no goiter, TPO is negative, no need for treatment. Dr. Nimisha, 12-year-old boy with poor school performance, FT4 is 0.6, TSH is 9, started on thyroxine, shock. What do you think was the cause? We discussed this in the beginning.
Cortisol deficiency might have possibly.
Yeah, so once he was completely fine because of low thyroid, his body was going on. You increase the energy levels, he suddenly went into crisis. So this was a cause which we need to be wary about, and always rule out central hypothyroidism in that perspective. Dr. Vibha, 12-year-old boy with weakness and hyponatremia, FT4 is 1.2, TSH is 12. Cortisol is 24, ACTH is 12. So what do you think is happening here?
Cortisol is low sodium, it should be high. So
Yes.
so is affected, TSH is affected, so it's a case looking like a case.
So you think this is most likely a APS-like picture or a pituitary-like picture? Look at the ACTH level. So it's a pituitary problem. But why isn't TSH high?
So TSH is within the central hypothyroidism, which it would be
Up to 20, but FT4 is not low. So that is the main concern. Now, whether this is actually hypothyroidism or is it because of a cortisol deficiency? So what does cortisol do to TSH?
TSH.
Yeah.
So it increases the TSH. It's not central hypothyroidism.
So we don't need to start treatment right away, and often on follow-up we'll find that the levels become normal. So if you have an isolated TSH elevation in somebody who has cortisol deficiency, don't treat with thyroid, wait for some time. There was partially empty sella with hydrocortisone, there was improvement which suggested that it was the cortisol deficiency which was causing. So when you have cortisol deficiency, you have masking of DI. When you have cortisol deficiency, you have masking of hypertension, you have masking of diabetes, you have unmasking of thyroid. So this is a different perspective to think of. 13-month-old boy with developmental delay, coarse skin, wide anterior fontanelle, FT4 is 3, very low, TSH is 2.2. What do you think?
So presentation looks like a hypothyroidism in this case, and low FT4 level with uh, normal TSH level probably indicates towards
Central cause, cortisol is normal. MRI show the hypoplastic pituitary. So which defect are you looking at?
this is probably this one is normal. So O1 F1 could be one.
Power F1 will be the most likely possibility in that regards. 6-year-old boy with meningitis, Nimisha, TSH is 0.1, FT4 is 6. Will you treat or not?
So we will repeat.
But they have to decide FT4 is low. The ICU person is asking treat or not treat. So what will tell you? This is more likely to be a non-thyroidal illness versus a central hypothyroidism. Look at the algorithm. So cortisol levels will give you a clue. Cortisol is high. So that saves you. This is because of a non-thyroidal illness. There is no need for treatment in that regards. 11-year-old boy, Dr. Vibha, with dengue fever, TSH is 12 and FT4 is 6. Again, you have a same sort of a picture. So what will you do? Will you treat or not treat?
The TSH is more than 10. So then
Yes.
if it's more than 10 in the admitted patient, we understand.
So this is very, very specific, very clear that when in endocrine we talked about contextual assessment, anybody who is sick should have a low TSH. High TSH means the actual TSH would have been much higher than this. So this child requires treatment definitely. Now coming on to management, the main management is of course thyroxine. The one which is easily available is the T4 medication. There is now some role of T3 in certain scenarios, like if you want to bring down the levels quickly, if there is a consumptive problem in that regards. So LT4, use the same brand, and remember that there is minimal role of T3, no role of weekly preparation. Some people used to use some weekly preparations always, which are required. Also remember that the requirements are higher if the problem is primarily in the thyroid versus the pituitary, and the titration which you have to do in the setting of primary is with TSH. For central, the titration is using FT4. You need to evaluate for autoimmune polyendocrinopathy in primary if there are features. For secondary, MRI and pituitary functions are essential, and target is to keep TSH and FT4 in the normal range. Now remember, if there is cortisol deficiency and you start thyroxine without hydrocortisone, there could be a crisis which is precipitated. The dose that you start is typically 100 microgram per meter square per day. So younger the child, higher the per kilogram dose. So 1 to 3 years, 4 to 6, 3 to 10, 3 to 5, more than 10, 2 to 4 microgram per kg per day. And typical dose is 1.6 microgram per kg per day in adults, which translates into 100 microgram per meter square per day. But do not start with this dose in somebody who has a long-standing hypothyroidism, which is pretty much most children who come to us with acquired hypothyroidism. So subclinical or severe cases start at a lower dose. And remember, it can be interfered using the various medications like calcium or iron, soy protein, light. So always keep it within that particular container, which is considered dark in that regards. You should do levels after 6 to 8 weeks, and then 3 monthly, and then 6 to 12 monthly. Keep target of FT4 in the high normal range, around 18 to 30, and TSH between 0.5 to 2. So if your TSH is high, FT4 is low, increase the dose. If your TSH is high and FT4 is normal in the initial phase, you may continue same. And if both are high, this is an adherence issue in that regards. And of course, if they are normal, nothing to be done. If TSH is low, you need to reduce the dose. After some time, TSH alone will be a good marker for long-term follow-up. There are drugs which can influence. So phenytoin, phenobarbital, if they are being started, the requirement will go up. Calcium and iron, most commonly PPIs, will increase the requirement, and use of drugs like octreotide or growth hormone can increase the metabolism of thyroid, and TSH may also be affected. If you need a very, very high dose in somebody who is having thyroid, then you think of malabsorption. Use of anti-epileptic or adherence becomes important, and always ask about calcium, iron, and proton pump inhibitors. You expect that once you start treatment, and we just had a girl today, although who was very much better in terms of height and weight, but in 1 year, She has gained 8 centimeters, lost 7 kgs, but the mother's main complaint is that there is now school performance has gone down. That is because they were adapted to a very low level and they were just studying. Now, once the thyroid becomes better, their mind is open and they are doing many other mischievous activities and they will gradually settle down. But if you start at a high dose, you may cause worsening of school performance. You may cause benign intracranial hypertension. So start at a gradual dose. Watch for headache, limp. So suddenly in the morning, they complain of pain in the knee or hip, difficulty in walking. This could be a clipped capital femoral epiphysis. This is not the effect of thyroxine. This is the effect of rapid growth. So this happens in growth hormone treatment. This happens in somebody who's just growing. Suddenly they may have this sort of a thing which may happen. So growth deficit may be there and maybe consideration for GnRH analog. Remember that a lot of hormones play a role. If you give growth hormone to MPHD, thyroid requirement may go up. If you are giving cortisol, they can also be an effect. So thyroid treatment may cause cortisol deficiency, and estradiol will increase TBG, requiring the dose of T4 to be increased. So these interplay may happen. 13-year-old girl, Dr. Alapan, FT4 was very low, TSH is more than 100. Given thyroxine comes to you with headache and irritability. So what will you do, and what do you think is the cause?
Probably the child is a hypothyroid for a long time, looking at the TSH level, and thyroxine has started in a higher dose. So probably you should have started in a lower dose and gradually build up the dose. The cause of the headache and irritability, if it is persistent, probably could be a benign intracranial hypertension in this case. So we should look for a retinal
papillary edema. Fundus imaging should be done in that regards. 15-year-old boy with follow-up on hypothyroidism treatment, otherwise was doing fine, but now complains of lethargy and weakness. You ordered the reports, FT4 is high, TSH is high. So Dr. Nimisha, what are you thinking of?
Adherence issue. The test has been done by taking FT4.
So you have taken a lot of tablets, the patient has taken a lot of tablets, that's why FT4 has gone up, but TSH takes time. So again, the point that you brought out is very important, that if you want to do a test, TSH can be done any time of the day, but FT4 should be done only before the tablet is taken. Otherwise, the results would be having an issue from that perspective. So adherence issue may be there. 12-year-old girl, stable on 75, weakness and lethargy. She was started on some medication, after which the TSH has gone up. So which medication do you think could increase the thyroid requirement?
antiepileptics like Benetton,
Okay, or iron. So a lot of other drugs can cause that. So calcium, iron, most common is iron. And a lot of people forget. So there has to be a 6-hour gap between the giving of thyroxine and iron to achieve a good outcome. 16-year-old girl on thyroxine 200, TSH is still 100. So what are the things you will think of, Dr. Nimisha?
Malabsorption like celiac disease.
Yes, and?
Hemangioma
Consumptive. Adherence, most common is adherence. They're not taking the medicine. So in this case, she had anemia and TTG was very high. I've seen many patients whom we identified as celiac because of the high requirement. Dr. Alapan, 4-year-old boy with MPHD on thyroxine 50, started on growth hormone. Suddenly the FT4 is going down. What do you think is happening?
In this case, growth hormone obviously increase metabolism of the
thyroid hormone. So the requirement is going up. This is unmasking or increasing the requirement, which may happen. 16-year-old girl with MPHD on growth hormone, thyroxine and estrogen, complains of lethargy and weakness. FT4 has gone down. She has recently been started on estrogen. So do you think estrogen can do this? So if you have estrogen excess, your TPG will go up and the thyroxine requirement will go up. So this is the cause because of that scenario. So we have tried to cover a lot in terms of hypothyroidism. We'll see if there are any further questions. We'll discuss those questions and then we will have a very interesting OSCE, which is there, which has been made by Dr. Alapan. So pituitary adenoma treat, why should not start a high dose thyroxine because of long standing? Because the body is not adjusted to that, Dr. Adele. If we start, there may be a lot of problems in that. How hydroxyurea affect hypothyroidism? One patient with SCD has high TSH in spite of higher dose of thyroxine. I'm not really aware directly at the moment of hydroxyurea, but we'll look into that and let you know, Dr. Naresh, on that. So we now will have the OSCE session, and for the OSCE session, we will ask all of you to put in the Q&A. So how it will work is that we will show you the questions and we will get the answers which are there in one of us, and then we let which is the correct one. So Dr. Alappan. Yeah.
Thank you, sir. Good afternoon, everyone. So I'll start with the first case. A 5-year-old girl child presented.
Yeah.
Presented with short stature. You can see the growth chart of the. It is a actually boy. Sorry. So concerned about the short stature, and you can see the growth chart plotting the height and weight. The TTG is 32, and he was diagnosed as a case of celiac disease. So do you agree with this diagnosis, and how would you like to proceed in this case?
So what are the pattern of growth failure is what Dr. Alappan is talking about? Is it endocrine or nutritional? So you can just write on the Q&A. It is not celiac. Dr. Ayesha has already mentioned. So do you agree, Alappan?
Yes, if you consider the height and weight, the height is affected much more considering to the weight. So probably this is a case of endocrine pattern of short stature. And if we further move into the investigation, we see the TSH level of more than 100 in this case. So this is a case of acquired hypothyroidism, which is misdiagnosed as celiac disease in the initial phase. And as sir always told that the better marker for diagnosis of nutritional versus pattern of short stature is a BMI SDS.
Okay.
Moving on to the next case, a 5-year-old girl child. She's concerned about weight gain for the last 1 year, and TSH level is 8.3. So she was advised thyroxine. She's an obese girl. So do you agree with advising thyroxine in this case?
So we can get the responses in the chat Q&A if you agree. So Dr. Neetu, Dr. Lana, Dr. Sajif, all of them are saying no. So yes, this is, I think, very, very clear message.
So basically the FT4 level is in the normal level, and TPO was negative. So basically this is an effect of obesity, not the cause. And anybody could explain the mechanism of this elevation of TSH level?
So which substance is increasing the level of TSH? So that is because of the
Leptin effect on the
leptin effect in the TRH. So Dr. Parag is talking about leptin on it.
So moving on to the next case, a 80-year-old girl child presented with short stature and constipation and diagnosed as a case of acquired hypothyroidism, having a TSH level more than 100. So she was started on treatment with 75 microgram per day, and certainly he developed irritability, worsening of school performance, and headache. So treating physician has reassured her mother that this is normal and it happens with every child. Do you agree with this thing, or do you like to move further?
Which test should be done, which will give you a picture like that? So Dr. Ayesha has already mentioned fundoscopy to look for papilledema. So this could be a benign intracranial hypertension. So Dr. Ekta is also mentioning cortisol should be done, sodium level, papilledema. So papilledema is something which we should definitely
look for.
look at. Very important presentation.
Yes. So moving on to the next case, a 80-year-old girl child presented with short stature and constipation, having a TSH more than 100 and diagnosed as a case of acquired hypothyroidism. She was started on 25 microgram per day and presently on 150 microgram per day. Still, her TSH level was more than 80. So what could be the possibilities of this high TSH level in this case?
So persistently high TSH despite a dose which is 3 times the expected limit. So Dr. Ayesha has talked about celiac, Dr. Edley talked about compliance, celiac, malabsorption. So I think it's going in the, absolutely the same thing we're talking about. Dr. Anshika also, and malabsorption and drugs interference.
And some drugs may cause this kind of picture which can interfere the thyroid function.
So we have discussed about
this thing, yes.
So that will be
anti drugs, iron, calcium, and other agents. Moving on to the next case, a 5-year, 11 months old girl child concerned regarding the short stature, which is an endocrine pattern. TSH is 4, FT4 is low, 10 picomole per liter, and diagnosed as a central hypothyroidism. So she got started on 50 microgram of thyroxine per day, and suddenly 1 week later he presented to emergency with shock and uh, other features of dehydration. So what went wrong in this case and what should be done probably in this case?
So I think this is a case which is very important. We should have done cortisol, as Dr. Neetu is talking about. Dr. Parag also is mentioning the same scenario. Cortisol, ACTH, Dr. Arushi test for other pituitary hormones. This is absolutely bang on. So I think this is one message which we want to give clearly, that if you have a low FT4 and a TSH less than 20, do not start treatment. Get a MRI done. Get a cortisol level done.
So moving on to the next case, this time 8-year-old, 9-month-old girl child presented with short stature. Total T4 level was low and TSH was normal. So do you think this is a central hypothyroidism or should look for any other test before confirming a central hypothyroidism?
So clearly we have got low T4 and TSH, but we need to know that most T4 is bound to TB. So we should look at that, I think.
So she was advised MRI, but the FT4 level was in this girl was normal. So before moving on to any other test, look for the free T4 level, whether it is low or not, before labeling someone as a central hypothyroidism. So moving on to the next case, 12 months old boy child admitted to ICU due to pneumonia, and the TSH level was low as well as the FT4 level, and she was again labeled as central hypothyroidism. So and advised thyroxine. So do you agree with this decision? And what is the test of choice here, which will differentiate between any other conditions present?
So in somebody who is admitted, very, very sick child, you find that the TSH is low and FT4 is low. So Dr. Arushi is mentioning cortisol. Yes, cortisol should be sky high. If it is non-thyroidal illness, it should be sky high. FT3, RT3, Dr. Aisha, yes, but that may take time, but better would be to do a cortisol, which will give you a much better picture. So both options are there. Do not treat unless the cortisol is low.
Yes. Moving on to the next case, a 7-year-old girl child presented with breast development and vaginal bleeding. As you can see, the SMA staging of this girl is B5M1 and the bone age is delayed 5.5 years. LH is low, FSH is in the normal range, and estradiol is 55 in this case. So what could be the next best test to diagnose this case, considering the context we are presenting?
So Dr. Anshika is mentioning FT4 TSH,
And
Dr. Nekta TSH.
So this is clearly a case of von Wiegrunbach disease due to the TSH receptor, TSH acting on the FSH receptor. So moving on to the next case, a 12-year-old girl child presented with TSH of more than 100, SMR of B2P1 and the bone age of 9 years, started on thyroxine, and after 1 year, she had developed the sexual maturity rating was B4P2 with a bone age of 11.4 year. So how does this child should be managed from here?
So what are the options? We've got limited time to grow. She was already pubertal and yet the bone age was less and it's increasing rapidly. So we need to do something to delay the bone age. And the option here would be, so JNR channel Dr. Neetu is talking about, yes, this could be an option. And this is something which we have used in some subset of patients with benefit, although there is not much randomized evidence. It will be very difficult to have randomized trial on this in that regards. So GnRH analog should be considered Dr. Aisha Zoladex. So yes, so all of them are absolutely right.
So moving on to some fact check, I'll give you a statement. You have to tell whether it is right or wrong.
So you can say Y or N, yes or no.
Yes. So the first question, the half-life of levothyroxine is 7 days.
So this is out of course. This will not discuss here. But yes, who will like to hazard a guess? Dr. Parag is saying Y. People are waiting. Dr. Aisha is saying no. Dr. Arushi, yes. What do you think, Dr.?
Yes, sir, it is 7 days actually, 7 days.
So that's why it may have a take time for TSH to stabilize. Yes, so it's 7 days.
Moving on to the next case, in Hashimoto thyroiditis, the thyroid gland is destroyed by the neutrophilic infiltration.
So do we agree with that? False, false, yes. So it's
lymphocytic,
not
neutrophilic.
Again, yeah.
Moving on to the next, the DiO2 the MDI1 removes the iodine of T4 from the inner ring to make it T3. So I want to know whether it is an inner ring or outer ring.
So this again is a tricky question. So Dr. Ekta, you should know, people haven't responded yet. So we talked about inner deiodinase or outer deiodinase. So what is your answer, Dr.
So it is outer ring.
So this is outer ring. So this is more of a theoretical.
Yes. So the puffy edematous appearance of the autoimmune hypothyroidism is due to the accumulation of the hyaluronic acid. Any answers?
So is it because of hyaluronic acid? Is it because of fluid? Is it because of fat? So Dr. Idly is saying false. So do you agree with that?
It is true. It is because of this myxomatous tissues.
So there are multiple factors there, but this is partly explained.
Yes. Moving on to the next question, the common site of dysgenesis of bone in hypothyroidism is the metaphysis.
So is it metaphysis, diaphysis, epiphysis? So Dr. Neetu says no.
Epiphyseal dysplasia.
So it is more of
epiphyseal dysplasia.
Not the metaphysis. Metaphyseal is rickets.
Moving on to the next, the Wolff-Chaikoff effect is due to the inadequate iodine supplementation.
So yes or no?
So it can be moved here. This side.
So Wolff-Chaikoff effect is because of inadequate supplementation.
So
So the answer is
no, it is the excess iodine supplementation.
so excess causes suppression.
So moving on to the next, the hung up reflexes are due to the slowing of the relaxation phase of the reflex.
So again, relaxation or contraction, which one? So the answer is
it is the relaxation phase.
True.
Moving on to the next, the amiodarone prevents the conversion from T3 to T4 to T3.
So amiodarone we know can do anything. It causes thyrotoxicosis, it causes thyroiditis, it causes hypothyroidism. So the question is very specific, whether it prevents conversion of T4 to T3 or not. The answer is, people have mentioned not yet. Yes, no, what do you agree? What do you say?
It is, it prevents the conversion of T4 to T3. Moving on to the next, the hemangioma produces DiO2.
Okay, so there are three types of monodiamidase, DIO1, 2, 3. So one is produced in the normal tissue, 2 is in the brain, 3 is in the peripheral tissue. So as Dr. Arushi said, it's mostly DIO3.
Yes. Yeah. So the last question, the most common thyroid disorder is shown in Down syndrome is subclinical hypothyroidism.
So Dr. Idil is saying yes, so I think that's true. Dr. Parag, Dr. Neetu, so there's a good consensus on that. Yes. So thanks, Alappan, for a wonderful quiz, which is really helping us in terms of trying to recapitulate whatever we have thought of from that regards. So this brings us to the end of this session, in which we'd like to go, all of you to go and have a look at our website to look at different aspects of pediatric endocrinology, look at the books, the publication, the mobile apps, and we will join again in a couple of months with the subsequent aspect of acquired hypothyroidism. Once again, thanks everybody. Thanks Dr. Vibha, Dr. Alappan, Dr. Nimisha, and the entire group of